Hello and welcome. This is Health and Wellbeing, and I am Lois Abasambo. This year marks 40 years since the acquired immunodeficiency syndrome (AIDS) was detected in the world, and the WHO is calling on global leaders and citizens to rally and confront the inequalities that drive AIDS and reach people who are currently not receiving essential services. This is in line with the goal to eliminate AIDS globally. But today on the program, we shall be discussing Nigeria's AIDS response and efforts so far in eliminating new infections in the country. Our guest today is the Deputy Director, Health Sector Response Support of the National Agency for the Control of AIDS, NACA, Dr. Daniel Ndukwe. You're welcome, sir.
Thank you very much, and thank you for having me.
And it's nice having you here as well.
Good.
Well, we're going to go on a short break. When we return, our discussion will comment on Nigeria's AIDS response. Do stay with us.
Following the sudden outbreak of cholera in some parts of the Federal Capital Territory, significant number of cases have been tested positive for cholera. The Health and Human Services Secretariat has intensified surveillance in the affected communities around the area council. Therefore, residents are requested to report any case of diarrhea to the nearest health facility or the Department of Public Health on the following numbers: Dr. Sadiq Abdurrahman, 0803 705 1784, or Dr. Doris John, 0803-315-6560. Ensure that the water used for domestic purpose is clean, boiled and filtered. Start ORS immediately you have diarrhea. Ensure that all food is properly cleaned and well cooked before consumption. Ensure that fecal waste are hygienically disposed of. Do not defecate in the open or into streams. Houses with surface wells should make sure they are covered all the time. Public Health Department, FCT Health and Human Services Secretariat. Announcer.
Welcome back, and thank you for staying with us. If you're just joining, this is Health and Wellbeing on ASO Television. Before we went on the break, I said we will be discussing Nigeria's AIDS response and what has been done so far in making sure that it is eliminated in the country. So, Dr. Ndukwe, how far would you say Nigeria has gone in its response to AIDS and eliminating AIDS?
All right. I think the best way to approach that is to give us some statistics. We do know that our prevalence peaked in 2001 when we had 5.8% prevalence. That to say about 6 individuals out of 100 then in Nigeria will be living with HIV. But the NIAID that was done in 2018, which is in fact the largest survey that has been done in the history of mankind, show that our prevalence has dropped as of 2018 to 1.3. So again, what that translates to say, if you were to get 100 individuals, you can't say one and 1.3, just about one person tending towards two will be having HIV. So we've gone a long way.
Okay, so we know that there have been programs upon programs upon programs, and over time we have seen them reduce.
Yes.
And this has actually affected, because we have totally not eliminated HIV/AIDS in the country. And the problem is now we're even having new infections. So it's not just treating the people that are already infected, but now having new and fresh infections. But looking at the fact that over time, attention to HIV and AIDS has reduced, and most likely even funding as well. Well, how is, since you're actually Deputy Director with NACA and you're the national body coordinating everything that has to do with HIV and AIDS in the country, how has it been so far? Saying that once funds and sponsorship may not be as it used to be, and then there's still quite so much work to do. How has it been so far?
All right, you just touched something very, very important. And this is one of the focus of my DG, because we're actually approaching epidemic control. When you start having like close to 90% of the population, or rather of people living with HIV, identified and put on treatment. That's to say you are almost, you would have reasonably reduced the rate of transmission. Now, and that is why, even though the global theme for this year is end inequalities, end AIDS, end pandemics, but Nigeria modified it slightly, looking at our context. So we are saying end inequalities, end AIDS, through sustainable HIV financing in Nigeria. Because, like you rightly mentioned, a few years back, we had quite a number of donors, large-scale donors, about 7 of them. But now there are 2 major donors that are still focusing on HIV in Nigeria. Talk about PEPFAR and then the Global Fund. And then we strongly believe that as we achieve epidemic control, it is just natural that they want to invest their money maybe into some other disease or other development concerns that they might have or interest. So, and it gives a sense of false security if you think we have achieved epidemic control, then we can now rest on our oars. That would be very dangerous. Because HIV hasn't gotten cure as of today. There's no vaccine that we know of that, prevents HIV. So when you reduce your emphasis on prevention and when you reduce the coverage for treatment, then naturally the ground will have lost, will have gained rather of start losing them. Because the behavior will keep continuing. Sexual activity is inherent in man. And then if we start indulging in unprotected sex and other means of transmission, that's to say the new infections will increase and eventually also lead to high prevalence.
Yes.
So I agree with you. And then that's why we're emphasizing sustainable financing, because you cannot do any intervention without financing. But then looking at the financing, it's not just government pumping money. We're looking at it from 2 major angles. We want efficiency. We want a program that will be effective, one, and also efficient, so that with the cost that the government can afford, we'll still be able to keep putting the HIV in check and not to completely eliminate it.
Now, you said something about not having a cure yet and not having a vaccine yet. But I believe that there are actually other methods in preventative methods, and to be able to see that people are actually caught. And one of those things I believe is pre-exposure prophylaxis, PrEP. I'd like you to tell us more about that.
Okay, so pre-exposure prophylaxis is one of the methods we are focusing on to prevent HIV in Nigeria. But you see, when you look at PrEP, it costs some money to put people on that medication. So it's not for we're not targeting everybody in the population. What pre-exposure prophylaxis pushes for is to say those who are at high risk of being infected. So who are this class of people? Like key population to us, we include female sex workers, men who have sex with men, those who inject drugs, and then transgender population. We're also looking at discordant couples. Discordant couples are, maybe the man is infected, the woman is not, or the other way around. One person is infected, the other one is free. And then we're also looking at people who maybe their work or their sexual habit or whatever exposes them to high risk. So for those people who are saying, in addition to our other preventive measures, including, proper use of condom and using it consistently, and then we say maybe being faithful to a sexual partner that is faithful and all that. Now, beyond all that, we're not okay. Let's also bring another measure that will also further reduce the risk. And that's to say they'll be put on medications, which are antiretrovirals, that we make it difficult for the virus to establish itself. That's what infection. Infection means the organism has established itself in the system of the individual. So that drug will make it difficult for them to have an established infection. And if that happens, that means they cannot be infected and they can also not transmit. But one other strategy we're also using in the country is to see if we can identify as much as possible, if possible, everyone who is infected with HIV and put that person on treatment. I remember last year about this time, we also did talk about U equals to U. If it's undetectable, viral load, it's also untransmissible. So these are all measures in place to prevent. Of course, beyond that, PrEP is like one big thing, but simple awareness, people to know HIV is still there, people to follow our ABC, abstain, be faithful to a partner who is faithful to you, consistent use of condom for those who cannot abstain, and maybe also prevent some other transmission. If we're able to put that measure, that would also be great. And that might be looking at people who are not, in quote, high risk. Because we don't want you to get infected. That you're high risk does not mean you are completely risk-free.
Yes.
Yes.
Okay, so one of the things that is very prevalent with HIV/AIDS is discrimination, and there have been so many advocacies for people not to discriminate against people with HIV and AIDS. And now talking about pre-exposure prophylaxis, this is a preventative measure, so something like if there was a vaccine, it would have been the version of what it is.
Okay.
Yes.
Yeah.
But now we have this issue of people that are negative having to take drugs, and one of the things is are they coming out? Are people who are high risk coming out to say, okay, I would like to have this? I've actually done reports on that and realized that they're actually scared of the discrimination, and most especially because some of the drug combinations are even for those that actually do have HIV/AIDS, and so they're like, when people see me with this, the first thing that comes is I'm infected, I'm positive, but I'm taking this as preventative. So it makes people become very reluctant to actually go out and actually explore this other option, But what is being done so far to try and make sure that, okay, people that are high risk, are at risk of getting infected, are made aware, and even apart from being made aware, to make sure that their privacy is actually protected, that, okay, they can actually come out and get this?
All right, so looking at PrEP and the drug, to start with, the awareness for those who should be using it is gradually increasing, and also the uptake, the demand is also gradually increasing among this population in question. And so when you talk about stigma discrimination, it's one problem that has remained with us, but I also want to tell you we are also improving over time. Improving over time. Before now, it is difficult to really say you're living with HIV. In fact, sometimes they want you to live in the same house with the person. You can't touch their bed. I was told in some homes they even have plates, cups, and all that just for you. You don't share other utensils. But we have realized that as we keep making the knowledge available to the people, discrimination is actually, and stigma is coming down. Also with the Anti-Discrimination Act or law that was passed, so it's also helping to curb it. But beyond the law is to keep increasing the knowledge of the people, because I know and I believe that discrimination is a function of ignorance. If you believe that shaking somebody's hand who's infected infect you, you say you don't want to shake hands. But we know HIV isn't transmitted. So we keep trying to push the right knowledge and the right narrative. Because when those things are not available, people create their own, and then they start acting on ignorance and start taking measures that is counterproductive to the whole of the national response. And then the other one too is to say these drugs are given to individuals, so it's left to the individual to know when and how to take your drugs. Okay, because it's given to them. You don't need to come to the clinic every day, because some people say, I don't want to be seen in so-called HIV clinic, because if you go in there, the assumption is that you're infected.
Yes.
So, but if you have your drug, you can take it discreetly in your house, in your own fine. But discrimination, stigma is actually coming down. It's not yet off, but we have seen some good improvement.
Well, discrimination is something that actually has to be tackled for people to be able to feel free.
Certainly.
Yes, and be able to come out for this. We're going to talk about self-testing.
Okay.
And that's something that actually helps in protecting people's privacy as well.
Exactly.
But before that now, funding for HIV and AIDS has really reduced, and we know that actually drugs for people living with HIV and AIDS are free. But for PrEP, is it free? And if it's not, how affordable is it for people that are at high risk? Because there's actually like a category of how you can take it, a number of days. Some people have to take it for as long as they feel that they are at risk. Yes. Yeah. So if it's not free, what is being done to see if is it subsidized for them, or tell us more about this?
Okay, for now, it's free. It is offered to them free, just like other antiretroviral drugs. It's given freely. The philosophy behind that free distribution of these drugs is because it's not just for the individual, it's for the public good. Yeah, because the individual will categorize whether key population, discordant couple, or whoever is at high risk of that infection has other sex partners that is, in quote, not high risk, that can be exposed. So if we're able to contain the infection by making such drugs available to the people, then that will be good. So it's free for now.
Okay, what about the availability? Or let's say for over the counter, and like we were saying earlier, them having to go to HIV/AIDS clinics. Is it at those places where they're able to access this, or are there other designated places for them to be able to access these drugs?
Okay, so for our commodities, and when we give it freely, we want to make them available in centers so that we can also monitor what is happening. So beyond general hospitals, some primary healthcare centers, some teaching hospitals, there are also programs across the country that has also identified the role that the community pharmacists could play. So there are some pharmaceutical, chemists where you can actually go and get medications and other commodities. But you see, they need to be monitored. Otherwise, the drug from being free can go into commercial for gain. So
because I was even going to ask, when you talk about community pharmacists, these are not government-owned institutions; these are private institutions. So is there like an agreement that this will be kept for people, or there are specific people that are registered with this pharmacy, or how does it work?
Okay, so it will work differently. But if it's for PrEP, those pharmacists are identified, the workers are trained, even the owner of the pharmacy, the pharmacist himself is trained, and then there's an MOU. Yes, so they make that drug available for those specific clients, that will also be told that these medications are available in so place, and they'll go discreetly take it just like any other person that's walking in, but you go there and then they make the drug available. So they go there for refills to pick drugs, and when they need to see doctor after some time, they'll say go back to doctor to see them, yes.
Well, we're going to talk about, like I said, private testing or self-testing, but that will come back from this short break. We're going to go on a short break right now, and when we return our discussion, we'll continue. Just stay with us.
Following the sudden outbreak of cholera in some parts of the Federal Capital Territory, significant number of cases have been tested positive for cholera. The Health and Human Services Secretariat has intensified surveillance in the affected communities around the area council. Therefore, residents are requested to report any case of diarrhea to the nearest health facility or the Department of Public Health on the following numbers: Dr. Sadiq Abdurrahman, 0803-705-1784, or Dr. Doris John, 0803-315-6560. Ensure that the water used for domestic purpose is clean, boiled and filtered. Start ORS immediately you have diarrhea. Ensure that all food is properly cleaned and well cooked before consumption. Ensure that fecal waste are hygienically disposed of. Do not defecate in the open or into streams. Houses with surface wells should make sure they are covered all the time. Public Health Department, FCT Health and Human Services Secretariat. Announcer.
Welcome back, and thank you for staying with us. If you're just joining us, this is Health and Wellbeing on ASO Television, and I've been here with Dr. Daniel Ndukwe, and we've been talking about Nigeria's AIDS response and what has been the grounds that have been covered so far. Now, before we went to the break, I said we're going to talk about self-testing.
Yeah.
And I know of two self-tests anyways. I know there's one you can do with the strip for blood, and then I've heard this new one that we do with saliva.
Yes.
And that's the one that makes me very curious because of so many things associated with saliva and HIV/AIDS. So you, in so many trainings that I've attended and so many advocacies, it's been said that the likelihood of transmitting HIV/AIDS through saliva is minimal.
Yeah, almost not there. Yeah.
Oh, yes.
It's not there.
And so how do we get to this point where we can now detect if you have HIV/AIDS using saliva?
That's an interesting question, but that question has been coming up a lot. So the way to look at it is this. What most of the test kits we have available do, they detect the antibody. So what is antibody? In the body's quest to fight the virus, the body produces some proteins, very tiny proteins. So those proteins are called antibody. They are molecular proteins that are produced to be able to fight the virus. Now, these proteins are found in different body fluids, including the saliva and found in the buccal cavity, that's in the mouth. So when somebody swipes, you are not just putting your saliva, you swipe on your gum and all that. Those antibodies, you pick them. So if that person is reactive, that means, because for you to have those proteins, that means you're already infected with the virus, that your body is now mounting up a defense against it. And among all, what your body does is to produce that protein to help fight the virus. So that protein is what you detect. So that protein is found in the body fluid, including saliva and in the mouth, but that does not mean the virus is in the mouth.
Okay.
So it's because some people keep asking, yeah, they say if you kiss and all that, you don't transmit HIV that way. We agree, but that does not mean the antibody is not in the fluid. And the antibody is not the virus, so it does not cause infection.
Doesn't. Okay.
Yes.
Okay. So now talking about self-testing and as it relates to stigmatization so far, for this test kits, how available are they for people and how can people access them?
Okay, so it's relatively new, the HIV self-test kit, relatively new in our, arsenals against HIV. Just a few years back, we started introducing it. So it is not that widely available. In fact, even the awareness is not even that much. So HIV self-test kits are test kits that are designed to be administered to an individual by himself with little or no assistant. So you have assisted self-test, the other one that is not assisted at all. So the idea is, one example I want to give is like to say the kit to test pregnancy for a woman.
Yes.
So that's the mindset. You can just go over the counter, pick it, go into your privacy, and then apply it. There are instructions that you can follow that will tell you the steps to take. There are also short videos you can always Google or go to YouTube that also you see somebody demonstrating the use. So it's not really that difficult. Like you mentioned, you can use blood. Some people are not comfortable pricking themselves, so they prefer the oral one. So the one in Nigeria that we have in our market is Oral Quick. And then you have the other one, which is they call Inst. Inst is the one that works with the blood or blood. Yeah. So you prick yourself and then you use it. So it's good, and like you mentioned, because you do it at the privacy of your house. Some people don't like going to the health facilities. Some people also wouldn't want to go to facilities that is within their neighborhood because I don't want my neighbor to say that I've gone or I've been tested for HIV, or what of that healthcare worker, will he expose my result, even though they are training, they are trained to keep information. Some information must die with the healthcare worker. So now, but some people will still say, fine, I'm still not comfortable. So you just go, test yourself, and then see the result, and then take the actions that you need to take after that.
But do you actually need to go for a confirmatory test after that?
Certainly, because even though the test is highly sensitive and reliable, it's very specific, highly, but you see, it's not all the positive that will end up being positive when you subject them to our usual testing algorithm in the country. So what we advise people to do is test. If you're negative, by all means, most likely that person is negative. But if a person gets reactive, that's so positive to the test, it might not be completely so. So you need to go to any nearby healthcare facility. And sometimes from the place you get that test kit, they might tell you the possible places you can go to confirm, or it can be in the booklet, in the leaflet inside. But if you go to our facility, they will now post you through the usual tests, determine, Unigo, and like, to confirm whether you're really reactive. Some people might actually come out not being reactive.
Now, what would be responsible for doing a self-test and you come out positive, but when you go for a confirmatory test, you come out negative?
A number. One is the oral test you did it yourself. You might not be so good with how it is handled. You might not have followed the instructions strictly. The test kit itself could have an issue. Because beyond that, even when we do, before the advent of self-test, that's why you see in our testing algorithm, you do the first line test, say, for example, determine. that person is reactive. You can actually try Unigo and find the person is negative, because the ingredients that test are not exactly the same in both of them, and different test kits have different sensitivity and specificity. So that is why even if you test positive to one, even outside our so-called HIV self-test, and we still need to confirm with another one to be sure that that person is reactive, because the test kit is not also, even if you have done it perfectly, it's not 100%. It could be 99.8, stuff like that. So it's not 100%.
So there's this thing I've heard of, some ailments that could actually make someone test positive.
Ailment, even
Educate us on that.
medications, and beyond the ailment and medications, you see the human system is complex, very, very complex. So individuals don't react the same way to the same thing. And then also that concept of window period, that somebody might not be reactive because you don't have enough antibody to be detected by that test kit. So those individual differences, and then some other thing that can mask it. And that's why, for example, if you are talking of the oral quick, you are asked not to do it within 30 minutes of having eaten anything, because those things can also have some molecules, some protein that can mimic or mask the very one you want to detect. So you give time so that the saliva would have taken it in your mouth, buccal cavity would have been clear before you apply the test. Yes.
So I'd like you to just give us a number of these ailments that could actually give a false test to that.
I don't know whether we have any specific one that has really been documented that I can remember now. But I won't be able to give you specific ailments. But if you have any disease that produces such antibodies that might mimic or might mask the existence of these other ones, but I won't be able to give you specific.
Okay. So we would not round up without talking about the COVID-19 pandemic.
Right.
It's something that cancelled 2020 for us and has actually affected so many things. So how has the COVID-19 pandemic affected the AIDS response?
I will start by saying resources are limited. And when COVID-19 it became the new sheriff in town, the big guy that just came into the scene. And with all the anxiety, the fear, the death, it is a novel sickness. People have so many questions that cannot be answered. Even government, scientists are a bit confused because this is new. Now, so what happened is that resource that's limited, whether money or manpower or time, you still need to pull from that pool.
Yes.
And then you divert some of them, or if you wish, even much of them to COVID. So that is one. So resources have been diverted. That is one. Then number two would be the issue of the lockdown. Lockdown did not only affect movement of individuals, but even commodities from across the globe. Not just commodity for COVID, commodity, medications, transportation, movement, last mile distribution, so many things were affected. So these are all some of the way that it affected. Some of the drugs that might be readily available will not be there. And then you go to the healthcare facility where the individual is to see the doctor or the healthcare provider. The healthcare provider at that was even scared. Especially you have fever around to see you.
Yes.
Even though the commonest fever in this part of the world might be malaria, cause of fever might be malaria and all that, but see, you are not sure that this is malaria.
Yes.
You are afraid if I attend to that patient or client, I can be infected. Some health workers will tell you I don't have personal protective equipment. So that really affected how COVID, affected our response, because it disrupted every system, including that of HIV.
So before we round it up, I'd like you to tell us NACA's efforts so far in eliminating new infections, so that once new infections are are eliminated, then we know that we just have to deal with people that are already infected. So what's NACA's efforts so far in eliminating new infections and seeing how HIV and AIDS can be eliminated?
No, that can take us a whole day. In fact, that's why we exist as an agency. If you want to look at the general population, people are at different risk of exposure. It could be occupation, it could be your lifestyle, it could be vulnerability, so many factors. So let me start by saying one of the ways for those who we consider that are not so much at risk is to keep, bringing the awareness. There was a time I was on one of the radios and somebody called in. He said, in those days we used to talk so much about HIV on radio, on television, but now we don't hear so much of such programs. So the impression now might be, okay, maybe it's no longer a problem. Okay, so now that awareness, so now we're trying to reemphasize again that prevention is very important. So people need to be aware. And when they're aware, you give them enough knowledge. Yeah, they want to believe that they might use that knowledge to safeguard themselves. And then we have a very rich condom program. Condom is distributed through to market approach. Some people are given free, some are given subsidized, and then we keep telling people how to use it. We've not forgotten abstinence. Some people tell you, so they kind of say it's not true. There are some people that can still abstain. And then we also encourage people to, for fidelity in relationships. So we still push out such narrative. Now, but then, the other strong point for us is this treatment. And we are really, really in the last mile of identifying people who live with HIV. Because when you identify them, including these self-tests we're talking about and other HIV testing services and strategies we have across the country, you get them and you put them on treatment and retain them in treatment. Because when you do so, their viral load, I mean the number of virus in their bloodstream would be reduced, sometimes become more detectable, so making it difficult to even transmit it to another person. So you can see all these things are working together to make sure that the transmission of HIV is reduced or is even completely absent. So that we'll keep doing. And NACA is working not just with us, we have a lot of good partners, PEFA, GF, and other partners, donors that have been supporting us, and also reaching out to state governments to be able to also take more responsibility and own the response, because that's become very important. Federal government can, somebody will tell you there's no place called Nigeria, but there's a place called Aso Hill. It's in Nigeria. There's a place called so state, so local government. And there are also leaders who are responsible for the people in those places. So fine. Why, if they step up, of course, with support from the federal government, fine. And NACA is also working with the private sector to also make commodities available, not just for treatment, but even test kits, make them available. So the strategies are just so many. So many, yeah.
Oh, it's great that NACA is doing a lot, and we hope that when we're getting to that point anyways, new infections will be eliminated and HIV/AIDS will be eliminated as well. But so far, I know there has been research on vaccines. Is there any headway?
Well, I'm not really in the center of the vaccine thing, but I know sometimes they tell you in less than a decade, they are hopeful. That was a few years back that the vaccine will be out. The funny thing about the virus is high rate of mutation changes its nature. It's just like what I say with COVID-19. A vaccine is out, but now we're told that one calls it Omicron. Omicron is out. And even though the vaccine will not completely protect you against Omicron, but it might make the severity less instead of being hospitalized or even outright death. So some of the evidence coming out is it might actually tamper with the severity, to your favor, to the favor of the affected person. So that mutation happens also a lot in the HIV world. So maybe they've not been able to get something that can really, really pin it. And that is why that emphasis has always been on prevention. And then for those who break through prevention and get infected, treatment. Because we have very effective medications. Some of them are even newer ones, less toxicity, the clients find them more tolerant, and they also quickly bring down the viral load, and they can live normal life. So HIV eventually has been pushed to where, the class of other chronic diseases, like somebody say, I have diabetes, I'm living with hypertension, so I'm taking my medications, I'm living my life. So that's how HIV is looked at now. You are taking your medication, you are living your normal life, you are productive to the society, you play your role in the family, so that's where we're going.
Oh, kudos for the job well done. But
Thank
before
you.
we round it up on the program, I'd like you to give a word of advice to our audience out there.
So our audience want to say, arm yourself with the right knowledge so that you don't judge somebody wrongly. HIV cannot be transmitted by kissing, by shaking, by sharing toilets, because some people will tell you it's toilet infection. I got HIV as I was in toilet. There's nothing like that. You can't get it from toilet. You can't get it from sharing utensils, whether a spoon or cup or plate. You don't get it that way. We know how HIV is transmitted. It's transmitted through sexual intercourse, especially what we call unprotected sex. The person not using condom or not using it correctly. It is transmitted through sharing sharp objects, something that can prick you and bring out blood, and then if you share maybe a needle, razor blade, or when you transfuse or save blood. It is also transmitted vertically from a woman that is infected who is not taking medication, because if that woman is infected, is taking antiretroviral drugs, you deliver your baby free of the virus. So if it is not in any of these I've just categorized, then please, you can't get HIV. Chances are that the people you have checked, all the number of them are living with HIV. Nobody can tell I never have it. So please, let's do away with discrimination. Let's do away with stigma. Thank you very much.
Thank you very much, Dr. Daniel, for taking our time to be here with us, and we sincerely appreciate your presence.
Thank you very much.
Thank
Thank
you.
you for having me.
Well, that's how far we can go on the program today, but do remember that you need to get tested for you to be able to know your status, and if you're negative, stay negative. If you're positive, please go on medication. Well, that's the size of our package today on health and well-being. Keep it to date with us. Same time next week. I am Lois. Appa Sambo. Do stay safe.